Je peux y aller, hein? Okay, we're going to start. I'm sorry for the delay, but we had to wait for the Spanish translation was there, so that's the good news. And we have, first of all, I want to present you to Professor Jonas Bergquist. Hello, Professor.
Hi there.
Professor will be interviewed at the end of my session that would take about 1 hour, 30 minutes. And I think it's very exciting, even for physicians, extremely exciting, because he's not going to talk on treatment. We're going to interview him on actually his accomplishment, achievements in doing a better diagnosis of fatigue and other type of syndromes. And you will see there's really enlightening new information. So Professor Jonas, you're ready? Okay.
A pleasure to be here.
See you in 1 hour and a half, and you will see it will be for everybody very interesting what you will see. So you can close your camera and your microphone, and I will start and share my screen. So for the Spanish translation, there you have to link to the link that is indicated there, and you will see it will be, it's a very good translator, so we're really happy to have Alexa doing it. And so now I'm talking about actually energy. I'm going to talk all throughout here how to get energy. And you will see it's extremely important. You can get energy through improvements of diet, nutritional supplements, but also hormone therapies that are fundamental to make a real breakthrough in severe chronic fatigue syndromes. So let's look a bit what is actually about fatigue. Well, it's the #1 complaint. Actually, when you go to my clinic, we did a survey many years ago, and we saw that the first complaint of patients in the main complaints is actually fatigue. The second being low resistance to stress, the third depression, and only the fourth on trying to stay young and healthy. So when you see a study here in Nijmegen in Netherlands, they interviewed people, and 2/3 of them had no fatigue, but 1/3 was complaining of fatigue. And among them, some had just short-term fatigue, but the majority had added chronic fatigue that was exactly fatigue that is 6 months or more. And when you look at those who have this chronic fatigue, 56% have disease, and those who have short-term fatigue, 34% have disease. So disease can create actually fatigue easily. And when among those chronic fatigue syndrome patients, 1% of these, that 31% actually, had chronic fatigue syndrome like fatigue. So severe fatigue that is really debilitating with inflammation, pain, and things like that, following actually a very strict criteria. And so this is really very common. And in consultations, when there are complaints in consultations, 30 to 50% of those complaints include fatigue. So it's really very common, and it's actually the most common complaint in the consultation. So that's why it's so important for health professionals, but also for patients to learn what we're going to learn here. We're just going to overview, so you're not going to see everything, but you will have a good overview on and know exactly where, in what direction to go to correct the fatigue. So chronic fatigue syndrome, there are actually many causes. There is, for example, can be hormone deficiencies. There can be nutritional deficiency. There can be inadequate diet. And there can also be just that digestion is not working better, but that's often also the result of inadequate diet. And also there can be just stresses, too much physical or psychological stresses. And there can also be multiple infections. Or there can be pollutants. And often many of those fatigues that don't go away are made by multiple of those factors. And so the physician and health provider has to tackle as much factors as possible as he can find in order to get the person back and energetic again. And I can tell you, even in the most severe chronic fatigue syndromes, we often have success by this multiple approach, not by just one miracle treatment. That is often not enough in fatigue, as is shown now in consultations. So physical activity can increase energy. That we know. People who move, they get more blood supply to the brain and the muscles, they can feel better. So this is one of the studies that shows association. So for example, people who feel fresh are actually, those are good, but those who just feel average between fatigue and freshness are 60% more likely to report insufficient physical activity. But when you go to more fatigue syndromes, like people really feeling tired, 2 times more report insufficient physical activity, and those who feel exhausted, 4 times more report insufficient physical activity. So the more there is fatigue, the less there's physical activity. It's probably consequences, but it may also be partly a cause. If you don't move enough, you get more tired. So here, what diet changes? There are many diet changes that can increase energy. And interesting is that in multiple sclerosis patients, who suffer actually a lot of fatigue, many of those are tired. Actually, when they receive a ketogenic diet with some medium chain triglycerides that are known to give energy, they have no real significant change of fatigue. They don't get more tired or less tired. It doesn't seem to matter. And they do have a lower fasting glucose, which normally will say that they may have more hypoglycemia and thus more fatigue. When you compare and you give to those multiple sclerosis patients a paleo type diet, and that's the diet that actually makes hormone therapies work better and where you get the most of the nutrients. That's a diet based on fresh vegetables and fruits and a meat and fish cooked at low temperature. So it's really a diet like our ancestors had, with foods that exist in millions of years on Earth and are not processed. When you give that, they have significant decrease in fatigue scores, those patients with multiple sclerosis, and they also are actually have a better cognitive function than if they would do the ketogenic diet, which is a high-fat diet and a low-carb diet. Drinks, are there drinks that give you energy? Yes, and it's very cheap. Water. Drink water, actually. Because then blood supply is all over better in the brain, in the muscles, and in organs. You see that actually the human body actually has and should normally have about 65 to 70% water, but in older persons get about 50%. In a very young, in the fetus or in the newborn baby, it's higher. But basically what we need to know for our patients, they need to go to the 65, 70% of water in them. And if they are 50%, they're dehydrated. And it's not only by a decreasing water intake, it's often by low hormones that keep water in the body. And so we need this for energy to get this water, because otherwise we're like a flower that goes away and seems to disappear, has no strength if there's not enough water. We are like flowers, and we need water, like flowers do. So for example, here's a study showing that people who have dehydration have a lower performance. And for example, these athletes, if they have a slight fluid deficit, not much, like 2% decrease, they have a decrease in performance during physical exercise. But if there are substantial fluid losses, you get this sort of very severe fatigue with severe health risk. There's even was a woman who was dehydrated, who died actually in a marathon not so long ago. So also alcohol. You think alcohol is good, gives energy? Wow, you're wrong. Alcohol, and you see here in younger adults, when they have greater than usual alcohol use, so those who drink the most alcohol, actually have more tiredness. That's especially valid for younger adults, not so much for the older. And they also have a shorter sleep duration. So it could be that alcohol, by impairing the sleep, makes that these younger adults are more tired. So, but alcohol is not a drink to give you more energy. And one of the reasons is that it decreases 8 hormone levels during many hours. Did you imagine that? That's why people who drink a lot of alcohol prematurely age, because of a lack of growth hormone, lack of cortisol, lack of sex hormones, accompanied by alcohol intake. And the lacks are not little. You have 70% lower growth hormone, for example. You will see this very important hormone for energy. So vegetables, for example, if you eat more vegetables, especially green leafy vegetables and tomatoes, there's less fatigue. Here are cancer survivors. We need to know that cancer, people who survive cancer often have more fatigue than normal. And some fortunately have not fatigue or little fatigue. And those are the ones who take more vegetables, have more vegetable intake. Unprocessed vegetables, especially green leafy vegetables like the ones you see here, the salads, the lettuce, and tomatoes also give better energy, probably, because it's linked to people with no fatigue. And what about proteins? Proteins, very important, because in amino acids, you have phosphorus. And the phosphorus actually provides energy. Most of our molecules that give us energy, like ATP and NADPH, actually have a phosphorus atom that separates, and when it separates, it provides energy. So high protein diet provide actually this type of phosphorus for energy. And when you look in male athletes, those who were put on a high protein, low fat diet compared to a moderate protein, moderate fat diet had actually lower fatigue scores, more protein, more energy, and less stressful feelings and less mood disturbances. So this is the kind of food with proteins you see, but also plant proteins that actually are good for energy. Put that in your mind, picture it, make a photo. And then you have also low glycemic diets, are actually diets with low in sugar. And when you look at young Japanese women, etc., fatigue was linked to the consumption of instant foods, confectionery, or full of sugar, and sugary drinks also. And between meal snacking, which are also often with sugar, are sugar derivatives. So that gives more fatigue. At least it's associated. So now you would say that's not true, because when I take a candy bar, I actually feel better energy. So I like taking candy bar because it provides me kick. Yes, momentary kick. Initially, it decreases tiredness. I agree. But 1 hour later, what happens? You have increased tiredness compared to initially. And you feel also more tense. So it's not a solution. And the reason, again, is like alcohol, sugar, when there's a peak in the blood, it blocks the secretion of hormones that increase the blood sugar because they're not necessary. So it blocks the energy-giving cortisol. It blocks the sex hormones. It blocks the growth hormone. And that tiredness is not for 10 minutes. It's for many hours or throughout the day till the evening. So don't take a snack full of sugar. And what about high glycemic drinks and snacks? Well, here it may have a usefulness. Before exercise, it can increase the performance. So we need to have competence in knowing when to take something high in sugar. Before performance, yes, but not when you don't have to perform. So we have also nutritional supplements that increase energy. Diet, there are many more aspects of the diet can improve the energy. Now let's look at the nutritional supplements. And we see here that there's increased energy in daily activities the whole day. Which are the nutrients that can increase that so you have a permanent energy the whole day? We're going to see that. We're going to see some, not all, because this is actually an overview of a model that has much more extensive information. I can tell you the 2 hours on nutritional supplements and diet are absolutely fascinating because it really will help you to help patients be better. And you'll know what exactly. There are supplements that also increase the energy in the afternoon that may be different than the ones that increase the energy the whole day. And you also have supplements that increase the energy just in the evening or mainly in the evening. And then you have supplements to increase energy during physical exercise and performance. And there are differences. And I'll teach you that. And when you will practice, you will see that what is said works in most patients. Also, there are supplements that increase energy in myopathy, degenerative diseases of the nerves and muscles. So let's look at some of the nutritional supplements that increase the energy the whole day. And I'm going to give you an overview here of what charges your battery and that of your patients. You have vitamin B12. When it provides energy, you do have a better energy the whole day. It's mostly by injections that works better, but at least it is one of the supplements that helps. We'll see in the model on with vitamin B12 what is the doses to give. The vitamin C also can be efficient, and when it's efficient to increase energy, it's the whole day. You have better energy. What I'm putting in red here are more important nutrients for energy. Vitamin D also helpful for energy. It makes a difference, especially muscular fatigue. But when it gives better energy, it's the whole day. Chromium also, especially in diabetics, it helps. And copper also can be helpful. We'll see the studies, but not here, I believe. And selenium also can provide energy. There are studies that show significant improvement of energy with selenium. And zinc also. And coenzyme Q10, also quite important, this one, but you will see there's a special dose to give. And omega-3 polyunsaturated fatty acids also help. Omega-6 also. Omega-3 comes from fish or linseed oil, and omega-6 is more from plant oils. Carnitine, also one of the most important ones to give energy. Ornithine, NADH, and sodium. You see, I haven't put iron here because it will give specifically more energy at a certain time of the day that we'll see, I think now, otherwise I will tell you. Pycnogenol is an antioxidant that also is known to increase energy in studies. So you will have evidence and you will have also practical tips. Vitamin C, let's see one of the studies where it suggests that there's increased energy the whole day. This is high users of vitamin C. Those who take daily vitamin C supplements, actually compared to low users, actually have 2 times less fatigue symptoms. Just a little tablet of vitamin C every day as a supplement. And you see that in alcoholic patients, actually, they tend to have very low vitamin C. Alcohol abuse consumes vitamin C, but also when you drink a lot of alcohol, you don't take so many fruits rich in vitamin C, so you have easily a deficiency. Only 30% of alcohol drinkers have actually an acceptable vitamin C level. So those alcohol drinkers or abusers are tended to have vitamin C deficiency. And the lower the vitamin C is, the greater there is a risk of having tiredness. So the more tired they are. And of the vitamin C supplementation, when you give it together with alcohol withdrawal, actually 89%, so almost all of these patients who are stopping alcohol and taking vitamin C report decreased tiredness. So it's worth doing that. Now, vitamin D can also increase the energy the whole day. And you see here, patients with fatigue actually have high prevalence of low serum vitamin D. You see here, adult patients, 174 with fatigue. So just taken in a consultation. And 77%, so 3/4 of these patients had actually low serum vitamin D below the lower reference limit of the laboratory, where normally only 2.5% are. And when you provide them with vitamin D, what happens is that you provide the vitamin D to those 77% who had low serum vitamin D. After you normalize the vitamin D, 2/3 of them had a lower total fatigue symptom score. So they were less tired. And they also improved in all the 5 subscales of fatigue that were assessed. And that includes that the physical fatigue was less, general fatigue was less, emotional fatigue was less mental fatigue, and more vigor. And actually the changes were between 30% less to 50% less of fatigue scores and 33% more vigor. So actually good effects of vitamin D supplementation. The dose you shouldn't use on general is at least 2,000 international units per day to make a difference. Coenzyme Q10 increased the energy also the whole day, but also, as we will see, at exercise. And here's a double-blind controlled trial where patients with myocardial infarction, they had acute myocardial infarction. After then, they received coenzyme Q10 because coenzyme Q10 is really protective for the heart. And what it showed, those who took 120 milligrams per day of coenzyme Q10 against placebo had 6 times less patients who were complaining fatigue. So in those patients with acute myocardial infarction, heart attack, 41% were complaining fatigue, and only 7% were still complaining fatigue in those who were taking coenzyme Q10. So 120 milligrams per day can be an efficient dose for background fatigue to decrease this whole day fatigue. For exercise, you need more. Carnitin increased the energy the whole day. And you see that 4 grams per day of L-carnitin increased the physical fatigue score, as you see here, and more than placebo, and also the mental fatigue score more than placebo in old adults with that have fatigue as soon as they start doing some physical activity. So it's helpful. Carnitin, but you need in general 2 to 4 milligrams of carnitin to make a difference. And so there are many, we know there are a lot more supplements that is seen in the session of the model on fatigue treatment. Let's look at some of the nutrients that increase energy in the afternoon. And the most important one of those is magnesium. And there are a lot of studies we'll see in details in the session and the model of magnesium, but here are some of the references that show a significant decrease in fatigue when you provide magnesium treatment. And I can tell you it's mostly in the afternoon. And why? It's because when you have a lack of magnesium, you're tense the whole morning. And when you contract your muscles, you get easier fatigue. And then that fatigue appears clearly in the afternoon because of this tenderness. And so this is really a fatigue that goes away by providing magnesium. You generally have other complaints like irritability that's very often linked to low magnesium, and that also go away with magnesium treat. How much should you give? Well, you need at least 200 to 400 milligrams elemental magnesium to make a difference. So you really have to look at, when you take a preparation, how much elemental magnesium in it, and don't take magnesium oxide. Most of the magnesium sold are magnesium oxide, but you are only absorb about 10% of that. So you need preparation like magnesium citrate, magnesium malate, or magnesium glycerophosphate to take, because you absorb much more of the elemental magnesium for that than from magnesium oxide. Magnesium oxide is just good for get rid of constipation. Now, how does magnesium increase energy and improve fitness? Well, the mechanism of all these of many of these nutrients will be examined in the session. I won't do it here, but it works at the level of the mitochondria to improve actually the fatigue and improve the battery. And I'll tell you where exactly it works. Here, it's good that you don't get confused, that a clear thinking, an overview of what you could do. Now, there are also supplements that increase energy in the evening, and that is mainly iron. Iron gives more energy in the evening, and you see that it decreases the fatigue in women without an anemia. So it's not the fatigue that you have is really due to lack of iron that is necessary as a cofactor in many metabolic reactions. And you see that this women without anemia that have unexplained fatigue, when you provide them with iron compared to placebo, you have a decrease after 1 month already of the fatigue score. So 4 weeks can be already sufficient, but generally it's a treatment for 6 months and gradually have better and better improvement. It works better in women actually with a ferritin that is below the 50 micrograms per liter. So the reference in young women of the ferritin is very low. Reference range is between like something like 30 and 110. And when you're below the 50 or at the 50 micrograms per liter, you already have fatigue, and you know that at that moment with iron, you will decrease the fatigue. There are also nutritional supplements that increase energy for sports. And one of those supplements here is vitamin B12. You really get, and one of the reasons why vitamin B12 works is that it improves the oxygenation of the red blood cells. They have a better volume, they're more mature thanks to vitamin B12, so it can transport oxygen better, and that gives a better energy. But it also works on the level of the nerves. The nerves have, when they have axons, it's surrounded by myelin sheets that make that you have quick impulses, and they can be quickly transferred, the nervous impulses. And with the vitamin B12, they're thicker, so you have a better conduction. So it works on several levels for energy. And vitamin C is also one that improves energy for sports. There will scientific studies will be shown about that. Vitamin D also, iron, coenzyme Q10, and omega-3 polyunsaturated fatty acids, and carnitine, and acetylcysteine, and magnesium. They all work to improve the energy for sports. So if you want to improve your sports performance, here are many of the nutrients that help: potassium, also sodium, and pycnogenol. So basically, you really have a group that of molecules you can improve your sports performance. And it's not to improve your performance always, but it's basically to make you healthier, because people who have more energy are usually people who are healthier, and these molecules help to improve your health. Here, let's look at one that is not so known, an acetylcysteine. Well, when you have an acetylcysteine, actually, it converts in the body to the very potent glutathione, which is a very potent antioxidant. And that provides more energy for physical exercise. So an acetylcysteine is the form easy to absorb of glutathione. If you take glutathione, it is easily broken down before it reaches the blood, and acetylcysteine not. And so here in men, who are athletic men, and acetylcysteine supplements were given, and when compared to placebo, and it showed that actually there was a significant preservation of performance here. So if they did a certain repeated exercise, they kept on longer time having the same energy, while those who didn't receive the acetylcysteine tired quicker. And it also significantly increased the plasma's creatine kinase over time, which is important for energy, an enzyme that helps for energy. It may have, if you give those that were taking of N-acetylcysteine, mild gastrointestinal side effects. Then there are nutritional supplements that improve the energy for myopathy. Vitamin D is an important one. I won't go into details here. Just mention it so you already have a tip where to go to, but to get all the information, I really recommend you to go and subscribe for the module on chronic fatigue syndrome and burnout. Now let's look at some of the hormone therapies that provide energy. When you think about hormone therapies, one of the major steps to do is think on where do they work the most. And when you know that, you also know when the fatigue that accompanies a lot of hormone deficiencies will be greater. For example, so what you need to know is what increases energy of hormone therapies is the morning energy, or afternoon or evening energy. Different hormones are evening energy, or whole day energy, or improves the sleep quality that improves the energy by sleeping better, or improves the energy and stress. It's generally a different hormone or different hormones that provide this better energy. Also more energy for sports, and more energy at rest, more energy standing up, more ability to recover, and less exhaustion, different hormones. And we won't look into all the details, but you will get some good information now already, what also decreases more burnout. So let's look at fatigue upon awakening. When you get up in the morning and you have early morning fatigue, and hypothyroidism is by far the most frequent cause of fatigue upon awakening. When you wake up tired, think first, you are, or your patient is, has a low thyroid function. And so it's a fatigue that is greater in the morning when you have low thyroid, and then improves during the day up to in the evening. And this is the thyroid deficient fatigue. And it slowly regresses during the day, and then when you're towards the evening, the patient doesn't want to sleep. He feels worse upon awakening, but he doesn't want to go to sleep in the evening because he feels the best at that moment. And the reason why is when you have a low thyroid function, blood flow is slow if you stay still. So you get awakened in the morning, your blood flow is really at its slowest, you have the greatest fatigue. But once you move and you feel better and better, and then your blood flow is better, it compensates. People feel much less tired. So here, for example, is a study that shows that to improve decreased fatigue due to low thyroid function, there are differences in preparations. The best preparations is those that have at least the two main thyroid hormones, like T3 and T4. So when you switch a person from T4 alone to T3, T4 combination, what you see is that, and that's a study that I published actually, is I had patients who were on T4 therapy, the most frequent therapy, but it's not very much working. And at least here, these patients that came to my consultation, 94% of these patients were still thyroid, despite they seemed to have an adequate dose of thyroxine. And when we gave a T3 to T4 preparation, what we saw is that most of these patients, almost all of these patients, had a decrease in fatigue, and about a third of them had no fatigue, or a quarter of them had no fatigue anymore with the treatment after 2 or 3 months of treatment only. And almost none did not improve. So really minimal. So really it works better with the T3 and T4 preparation than just with T4 alone, because T3 is the most active thyroid hormone. When you go further, it works even better with desiccated thyroid hormone than a T4 preparation. So patients who were trying the TOD, they took L-thyroxine and T3 and T4 combination or desiccated thyroid, and actually only 19% preferred LT4. And desiccated thyroid was taken also for 16 weeks, so about almost 4 months. And what was showed that nearly 50% of the patients, of all these patients who had hypothyroidism, preferred desiccated thyroid. They didn't know it was. They said it's preparation A, for example, is better. Preparation A is desiccated thyroid. It's a placebo-controlled study. And so not only a better energy level, but they had a better concentration, better memory, better sleep, better decision-making capability, and why not? Better happiness. So if you want to be happier, take desiccated thyroid. I can tell you, I have hypothyroidism. This is the one I take, and it's the one that I prescribe the most to my patients. You also had a better weight loss when desiccated thyroid was given, and the reason is that desiccated thyroid powder, actually from thyroid gland of porks in general, has actually not only T4 but has T3, the very active one, the most active thyroid, has T2, T1, T0, and we'll see also with Professor Bergquist that actually even T3 can have different 4-dimension structure, so that it could be that you have several forms of T3 in those preparations that make actually thyroid therapy even better. So thyroid supplementation, how quick does it increase energy? First month in general, there's little or no improvement in the patient. And second month, there's more energy and less fatigue. It becomes clearly apparent. And then when you see this patient becoming like this with more thyroid hormones, it's mostly the third, fourth, and fifth month that there's further increase of energy and fatigue. So I warn my patient, don't expect too much the first month. Second month, you start improving. And that shows out to be often true. Some improve very quickly, but that's an exception. So you have a certain delay in beneficial effects. And it's also the case with other hormones, but it's even more with thyroid hormones because we always start at a low dose in the beginning and then gradually increase. So you cannot have so much efficacy. So fatigue is stressful condition, can be due to cortisol deficiency. This is a fatigue that's the whole day. And you see that there are peaks of stress in the day. And at those stress peaks, patients feel, oh, it's too much for me. And in the evening, the cortisol storage is depleted. There's no cortisol enough left. There's aggravation of fatigue, and the patient is not able to work anymore and goes often quick to bed. So fatigue at stress is typical for a cortisol deficient fatigue. Cortisol is a very good molecule. If we don't have it, we die within 24 hours. Did you imagine? So it's only that when cortisol is given, it has to be given at the same time with DHA that protects against the adverse effects of cortisol given alone. How does cortisol increase energy? Well, basically, it will increase the sugar in the blood. So there's more sugar for all the cells. And it also, there's more sugar that comes in the brain cells, in the heart cells, in the muscle cells, in the liver cells. It also increases the glycogen stores, which are actually stores of glucose. This is a glycogen molecule. And these are all sugars. And it also increases the blood ketone bodies. You see acetone, acetoacetic acid, beta-hydroxybutyric acid. So it gives energy by two ways. We know that when you're on a ketogenic diet, there's a diet with high fat and no carbs, the fat is getting released on the form of ketone and give energy and supplies for the lack of blood sugar. And blood sugar and ketone bodies will increase the ATP production. And ATP is the energy molecule. We make a lot of ATP per day, and so the stores have to be constantly increased again. And that is helped with cortisol. It's really an energy hormone. It also, cortisol increases the blood pressure. So you just more blood flow in the brain and more nutrients getting into the brain. There's more heart and the more blood flow and nutrients getting in the heart and in the muscles. So it's cortisol, just a better blood pressure gives a better blood supply all over, and you have better energy. Now, here's a study showing that 20 to 35 milligrams of hydrocortisone improves well-being in chronic fatigue patients. Just to remember you, when we talk about chronic fatigue syndrome patients, we talk about the most tired people in a population, the 1%, the most tired people. And we give them hydrocortisone without even measuring the cortisol levels, but they are low anyway in most of these patients. You give them for 12 weeks, so about 3 months. And so they have actually higher levels of 30% more cortisol. That gives a significantly improved the self-rating wellness score. And they are thought that almost 2 times more patients reporting an improvement, more than 5 points in the wellness score compared to placebo. So very important hormone. Now there's another very important hormone, and that supplies actually energy in prolonged upright position. It's aldosterone or fludrocortisone supplementation. And when you feel drowsy in your head, when you stand up a long time or you're sitting a long time, that's usually because your blood pressure is too low, and that is usually due to low aldosterone. Now, aldosterone keeps salt and water in the body, so it decreases blood pressure. So if you don't have enough aldosterone, you have low blood pressure. And when you give a treatment, for example, you provide fludrocortisone, and it's exactly what you can find in pharmacy. Aldosterone in the pure form you don't find, and even if you have it, it gives a good effect, but it's not long-standing. While the fludrocortisone, it works on the morning towards the evening. So I have an aldosterone deficiency. This is the one I take, and I take 100 micrograms is the average dose. But there are some need more and some slightly less, but generally 100 is what most need as a minimum. And here's a study showing that when you give to chronic fatigue syndrome patients fludrocortisone, you give 100 micrograms for a long time, almost half a year. You have much lower fatigue scores, less mental fatigue, 2/3 decreased, lightheadedness, that is typical for aldosterone deficiency, decreases, more better mental function, and more better general sense of well-being. So you really have a difference. Now, there's also hormone fatigue due to disturbed sleep, when you don't sleep well. And one of the reasons not to sleep well is that you have to go constantly to the bathroom. And so desmopressin is the synthetic derivative of the bioidentical vasopressin that you cannot get at the pharmacy, but you can get desmopressin as a tablet, and you just put it under the tongue, let it melt, and improves your quality of life because you have less to go to the bathroom. It was given to patients who at night had to often go to the bathroom, and you have less nocturnal voids. And actually, because they improved their sleep, they had better energy. This is a double-blind placebo-controlled studies in adults with nocturia. That's the fact of having to go to the bathroom at night often. Women with nocturia, men with nocturia. It's over and over again shown that this helps to improve the situation. Now, there are hormone supplements that increase the energy the whole day. So when you see a patient, you need to ask the question, are you tired the whole day, or tired in the morning or in the evening? And hormones that give energy the whole day is estrogen. So what is red is really very typical. The fatigue due to low sex hormones is the whole day there. It's not a severe fatigue, but it's all there all the time. Progesterone in the premenstrual period, when there's more fatigue, premenstrual period could be due to progesterone deficiency, and it's healed in these women with progesterone. Testosterone, also very important. Thyroid and growth hormone, IGF-1, but those two also can give severe fatigue, but they're more marked by other characteristics. Thyroid withdrawal really the characteristic is that the fatigue is worse in the morning, by far more. And when they sit still, they don't move. Growth hormone, as we will see, is a fatigue when you are completely exhausted and you don't seem to recover over the years. DHEA, slow. Insulin also gives a whole day fatigue when it's there. And so let's look at the permanent fatigue that is provided due to sex hormone deficiency. So the usual cause, is the most frequent one, is estrogen deficiency in women and testosterone deficiency in men. So it's really typical. You can, just by knowing when the fatigue comes, know what is or likely is the cause of it, the hormone cause. So when you have a permanent fatigue that is whole day, it's not severe, so this is slight, but it's there. Think about sex hormone deficiency. It's there, the same intensity. And provide then the missing hormones, of course, after doing the lab test, doing a more deep investigation by physical examination and by asking the questions that are on the symptoms of deficiency. Here's just, some information on the permanent fatigue that can be found in some women in the premenstrual period. You see that these women who have more premenstrual fatigue in the second phase of the cycle, before menstruation, have lower serum progesterone, so that this progesterone is lower in the blood. And it's an inverse relationship. The lower the progesterone, the more fatigue there is in the premenstrual period. And it's possibly because actually when you have low progesterone, you're nervous. So you tense your muscles and you move a little bit too much. You move too much. So you have actually, you get tired from this sort of tenseness in your muscles. And also you don't sleep well. So you have a poor recovery during the night. Two reasons why progesterone may, when it's deficient, may increase fatigue. Now, when you have DHA deficiency, you can also have background fatigue, insulin deficiency. Also, we're not going to details here. You just go and look at the session in the model on chronic fatigue, on hormone therapies and chronic fatigue. Let's look at some of the permanent fatigue can have, but that increases when there's physical activities. It can be due to hormone deficiency, and that is in the most of the cases that are number one cause, testosterone deficiency. So when you're more tired when you do the sports than you should be, think that there's not enough testosterone and you can do what you want. Training will help, but it also will help to supply the missing hormone that you might have. And there are studies showing that when you overtrain, your testosterone levels go too low. When you are overtraining, is sort of burnout for sports people. It is often linked with a lower testosterone. And you see, so the testosterone fatigue is a background fatigue, but that increases when there's sport activity. So the people who have testosterone deficiency often do not want to do much sports because it tires them too much. Even if they do a lot of exercise, they don't seem to recover. So they end up by stopping doing sports. Now, let's look at a study on women taking oral female hormones. Well, they usually have lower serum testosterone levels. And the lower the serum testosterone is, the lower the testosterone is blood, the more they self-report. The more the self-report energy is, they have less energy, the lower their mood is. So the lower the serum testosterone is the more the quality of life is not good. There's really a significant association. They need testosterone. And actually, I'm not going to talk here, I think, about that, but when you have a woman who's collapsed, has no energy, and you give treatments and it doesn't work, that woman needs testosterone, but that woman needs to have higher levels of testosterone. So testosterone injections with a blocker like finasteride that blocks the conversion of testosterone to dihydrotestosterone, and so they don't get masculinization of their body, but they do fantastic with that sort of injectable treatment once a month. So testosterone gives really physical energy to men and power, especially to do physical activities and sports. And they want to do sports. Men who want to do a lot of sports often have a lot of testosterone. And so when there's testosterone deficiency, there's definitely more fatigue in men. And here you see, for example, in obese men who have who are snoring at night, have obstructive sleep apnea. If they have lower serum testosterone, and they have lower serum testosterone, well, the lower the serum testosterone is in them, the more fatigue they have. So, when you have a low serum testosterone, you have more physical fatigue and you're less active. Of course, you're less active if you are more tired. It's really an energy hormone, testosterone. And in women, you see, some women have this mental collapse. Well, I'm seeing here the extreme mental fatigue that responds to nothing. You give them growth hormone, you give them cortisol, you give them thyroid, you give them nutrients, you improve their diet, and they stay collapsed. they're sick and tired of being tired. They really get down. They see no, not the end of the tunnel. They don't see the light at the end of the tunnel. The light at the end of the tunnel is going to your consultation. You're the genius. You're the good person who's going to help that person out. And how do you do it? You have a patient who's 5 to 20 years in collapse situation. Give 2 to 4 months of testosterone injections, and they become brilliant women who can become prime minister, head of state, or at least very good businessman, dominant, self-determined, knowing what they want. They're going to do that. They feel they have the energy to do it, and they do it because they really have the energy. Determined woman, brilliant woman. Men like to have brilliant women. That's the dream of men, is to have a woman who's very dynamic, knows what she wants. They don't want to be dominated by women, but they want to have a woman with strong personality. Testosterone gives a strong personality to women. Leadership. It's even more remarkable in women than in men, the effects of testosterone. Now, if the patient is physically exhausted, there's a mental fatigue, doesn't see a way out, and it's also mental and physical, and they need to stay a long time in bed. That's very typical. They stay 12 hours in bed, and that's not enough to recover. They never are able to recover. That sort of fatigue, exhaustion, that's growth hormone deficiency, for sure. And after age 50, most people also become IGF-1 deficient. They're not the same. IGF-1 is insulin-like growth factor 1, is produced by the liver. Growth hormone is produced in pituitary gland. And growth hormone stimulates the production in the liver of IGF-1, but after a certain age, after age 50, it's not enough. You need to supply additionally IGF-1 to get out of the fatigue. I was very good with growth hormone from age 38 to 50, 52. But then suddenly I started to be tired and I had no relief. When I took IGF-1, wow, in 1 month time, my energy came back. So when you have a lack of growth hormone, the fatigue is severe. And it's all day long, but it aggravates towards the evening. And if they go too late to bed, it's worse the next day during several days. So this is really exhaustion syndrome that it gives. It worsens towards the evening, but it's there in a severe state all the time. They also don't sleep well with growth hormone. You get more superficial sleep that you don't seem to restore. Insufficient recovery. And so in chronic fatigue syndrome patients, the levels of growth hormone secreted at night are actually, compared to controls, about 50% lower, 2 times lower levels. And because a marker of growth hormone activity is the IGF-1, growth hormone stimulates production of IGF-1, the IGF-1 is about 40% decreased in chronic fatigue syndrome patients. So no wonder they remain chronic fatigue, because they cannot recover anymore. Between age 31 and 38, I couldn't recover anymore. I could work, but after 7 or 8 hours of sleep, I stayed tired all the time. And actually, I didn't really know that. But at age 38, when I took growth hormone, imagine my surprise. I took it because I needed for a patient. I want to check it. I wasn't tired anymore. And I became fresh again as I was at age 25 in the spring. But I was in the winter when I took it for the first time. After a few weeks. And so I could recover, and I slept 5-6 hours at night only. It shortened my sleep, but it was much better quality, and actually I could do much more. I needed the sleep. Growth hormone, what are the doses to give? So just to show you that I usually give doses to give to you, you know exactly what to do. I'll give you some information about growth hormone. Growth hormone is a hormone produced in the pituitary gland that consists of 191 amino acids. And the doses that to give is between 0.05 to 0.4 milligrams per day. The only thing you really need to be careful after doing a diagnosis, of course, you don't give growth hormone to any person. But you have to have a diagnosis of growth hormone deficiency. But you need to be checked that that patient doesn't have an additional cortisol deficiency, because growth hormone decreases cortisol, and if it's already too low, the patient will certainly have collapsed levels of cortisol, and then not feel good. Where do you inject growth hormone? You inject in place around the belly or on the external of the thighs, a little injection under the skin. In the abdomen, thus external thighs is the most frequent place. You could put it somewhere all over your body, wherever you want, but basically these are the places that mostly used. You need to change place all the time. And very important, when you inject, don't do it like it's shown on internet. Extend the skin. You extend the skin, you don't pinch the skin. Otherwise you get a blue spot by injecting in. So on the external side of the thighs or on the lower abdomen, no skin pinching. Don't do it like this, like it's shown on the internet. It's wrong. Now there's also fatigue due to the fact that you don't sleep well because you or the patient is melatonin deficient. Melatonin makes you sleep better. So for example, here it shows in patients with childhood craniopharyngioma, they may have low melatonin levels. And the lower their melatonin is in saliva, the more they suffer from daytime sleepiness. So you're at night not having enough melatonin, you don't sleep well, and thus you have more daytime sleepiness. So at school, it's hard for them. So they actually need melatonin at night in order to sleep better and have less daytime sleepiness. So melatonin treatment, for example, and when you give it to patients with chronic fatigue and delayed sleep phase syndrome. So what is a delayed sleep phase syndrome is the fact that you go too late to bed because you cannot fall asleep earlier. And when you give 5 milligrams per day of oral melatonin, which is high dose, but when you need to change the rhythm and make the patient sleep earlier, you give a higher amount in the beginning, and you give this 5 hours before dim light melatonin onset, and they really improve their strength scores are better because they sleep better. They have less fatigue. They also have more activity, more concentration and motivation, and a really normalized score fatigue. And so that really helps. Now, I would do it differently. In my experience, you just need to give melatonin before half an hour to 10 minutes and not 5 hours before going to sleep at bedtime. So if your bedtime is 10 o'clock or 11 o'clock, you take it a little bit before, close all the lights, and you will sleep well. But you just need to give to people with delayed sleep syndrome a higher amount of melatonin the first month. And then you can go to lower doses after they have reset their circadian rhythm of melatonin. Of course, we'll see patient cases, etc. During all these sessions. At each session, there's patient cases. And here's, for example, we'll see an example of Christian, who was a severe chronic fatigue syndrome, was stayed in bed all the time because of the fatigue since 5 years. And she had, this is the picture of her fatigue from morning to the evening, very intense fatigue. It was a permanent background fatigue, a physical effort. So she knows she has testosterone, estrogen, progesterone deficiency. And it was also a severe fatigue if she got too late to bed and poor recovery. In the morning, she had more fatigue. She had also more fatigue in vertical position, low aldosterone, and at stress. And in the evening, she also had iron deficiency and things like that. So basically, in order to help these patients, you need to provide all the hormones and nutrients they are missing of to really get them out of fatigue. And I succeed in getting her out of fatigue, but you will see in several stages. I didn't correct everything in the beginning, and you see that she kept part of the fatigue. But it was so severe that there's one treatment to make the whole difference in this patient. I can tell you fascinating growth hormone. And I wasn't, it was almost, except one patient, it was the second patient I ever treated with growth hormone, but it was miraculous. Took out the exhaustion. Now let's look at burnout. And burnout is really a pathology that is more and more, even more with the COVID-19 now. And so some people get the COVID and they don't seem to recover after. And now we have also people getting the vaccine and not recovering after. And when you look at the studies, but you look also at these patients, they have complaints and physical signs of hormone deficiency. And so there's a suspicion that the burnout symptoms in physicians, for example, this study done in physicians here, when you look at the different burnout symptoms, that corresponds to hormone deficiency complaints. Typical of hormone deficiency, fatigue and exhaustion, the gastrointestinal troubles, the anxiety, the irritability, the aggressiveness, and also work-related symptoms and interpersonal symptoms can be typical of hormone deficiency. And so in the fourth session in the chronic fatigue syndrome model, we'll go in depth on all these different hormone deficits. And what happens in these burnout syndromes is that they had too much stress too long, or they had an acute severe trauma, and where they overproduced hormones and they overconsumed hormones, and at a certain time the gland doesn't work anymore. It's overused. There was too much spilling of hormones, and you have a premature aging of the endocrine glands, and you get then chronic multiple hormone deficiencies, and you get then the burnout. And what they, of course, will be better by doing much less activity because they're not able to do more, but it's because they have hormone deficiencies. It's not psychological. It's because the hormone deficiencies are there. So as long as you don't correct them, you won't have an improvement. So burnout has, and that's critical, as almost in all cases, low cortisol levels. There's the lack of punch that they have, the lack of fighting spirit, that really is typical for cortisol deficiency. And when you give cortisol, results are good. But the problem is that they have multiple hormone deficiency. So if you just correct one and you don't correct the others, it doesn't work well. So you need this, again, multiple approach, including multiple hormones, to get out of the syndrome and get back to work and to have a life worth living. Because being burnout is not pleasant living. It's suffering. Why would you suffer if you can solve it? And you, as a health professional, as a physician, are able to correct that. And if you're a patient, you can find a doctor who's able to correct it, because it's really worth it. It's your life, and your life is precious. You're the star of your life. So if you treat yourself well, you'll be able to treat others like they are also the star of their life, so that they have a life really worth living and a future. So when there's burnout, there are also stress feelings. It also may result from cortisol deficiency. This irritability, where it can get suddenly very aggressive. That's typical for cortisol deficiency. With anger outbursts. And who has not been like this when being very tired? Because when you work too much and you're too much in stress, you end up by having cortisol deficiency. Again, the treatment is to give cortisol. Let's look at and we'll see that in the session on burnout, that is really worth seeing, is that these are the levels of the cortisol in healthy persons. So what you see here is that there is, during the day, in the morning, there is an early morning peak of cortisol. At night, there are lower levels. This is the evening, lower levels at night and evening. Low night nadir, that means lower point. And there's a gradual decline from the morning peak towards the evening, a gradual decline of cortisol levels. And they are during the day short peaks in stressful situations. This is the healthy situation. Being able to adapt and make more cortisol during stress. In burnout patient, it's completely different. Their overall serum test cortisol level is much lower, so they have less cortisol in blood. And the lower the morning peak is of cortisol, the more severe the burnout symptoms are. So you need this morning kick of cortisol, this peak level, to get the energy to be able to go into your day. So this is a typical person with low cortisol. You see also that there are dark circles under the eyes here, that there's fatigue. So low serum cortisol are found in high burnout patients. And the more severe the burnout symptoms are, the lower the cortisol levels are, and the smaller the cortisol awakening response is. This peak level in the morning is called the cortisol awakening response. And the lower the cortisol to DHEA sulfate ratio are, the higher serum DHEA levels are to compensate. So when you're not able to make enough cortisol, the body tends to make more of the other adrenal hormones to compensate. But ideal is to make more cortisol. And so the adrenals are weaker if you can suppress their action easier by giving a synthetic derivative of cortisol that stays 2 days in the blood and suppresses then the adrenal function more than the bioidentical one, the dexamethasone. And what happens then in patients with burned out is that their levels are much lower. So there's a lower morning serum cortisol peak. There's lower afternoon cortisol. There are not enough levels to have the energy to go through your day. And there are insufficient short-term stress peaks. They're almost not able to increase their secretion of cortisol to adapt to the stress. So when you give a treatment, you give hydrocortisone, that's bioidentical cortisol, and burned out. What happens is that if you give them 35 milligrams of cortisone, they have less fatigue, more vigor, and it also increases, in this case, the serum prolactin, which is a stress marker. It works mostly in those who have high prolactin level and burned out. That means that they are under stress, actually. It works more in the high in burnout patients who are high under stress. Burnout also can be linked to another hormone deficiency, aldosterone deficiency. And aldosterone deficiency is like this person you see here. What he has is a sort of feeling like he's going to faint. And people who are fainting now by taking the vaccine, the COVID-19 vaccine, are actually have low aldosterone. Otherwise, they wouldn't faint. They have done low blood pressure easy and faint easier. So look, athletes who overtrain, 7 runners here with this overtraining syndrome, typical of them, they had low aldosterone levels, as well in stress as at exercise. So their blood pressure is not high enough. Also had low cortisol levels. Cortisol is low in all these overtraining, burnout syndrome, etc. Now, what about the burnout and thyroid hormones? Well, there are conflicting evidence. In some studies, there's too low levels, some studies too high levels of thyroid, and then they have heartbeats and things like that. So basically, we'll see how to distinguish between the two types during the session on it. What about the sports fatigue? Well, sports fatigue, when you need to use your muscle, think in first place, testosterone deficiency. And burnout can also have growth hormone and IGF-1 deficiencies. And typical when it's due to growth hormone deficiency, there's a sort of feeling that you don't have the power to confront what you have to confront. Because growth hormone gives you a sort of inner peace, and you see clearly, and you see you can do this, and that is the solution for this. But if you don't have enough growth hormone, everything gets confused and looks to be too much. You're overwhelmed. You're drowned in the things. So you feel powerlessness when you're low in growth hormone. And that's typical also feeling that people with burnout have. So it may result from growth hormone deficiency. And people with growth hormone deficiency tend to want to stay at home and sheltered because they have social anxiety. They can have panic attacks. Well, panic attacks is actually linked with people with panic that have 60% lower serum growth hormone, because this is a reassuring hormone. So if you don't have enough, you have easier panic attacks. And then you have the post-traumatic stress disorder, which is, in my experience, due to trauma, of course. But the problem, it has created hormone deficiency, and you need to correct the hormone deficiency. Well, these Vietnam veterinarians were suffering from post-traumatic stress disorder. And what you see is that they have significant lower growth hormone secretion. You cannot detect growth hormone in most of men and most of adults actually during the day, because it's mostly secreted at night, and during the day, small little short peaks. So you have to stimulate it with clonidine, for example, and that stimulation doesn't give much growth hormone either in people with post-traumatic stress disorder. So they're growth hormone deficient. In burnout, there's likely also low melatonin, because burnout, they have sort of agitated sleep. They're nervous at night. They don't sleep well. And melatonin makes you sleep like a baby, calm and relaxed. Here, for example, again, post-traumatic stress disorder patients and effectively personnel from the Canadian Armed Forces. You see here one. And when those with post-traumatic stress disorder compared to those who were not, have definitely lower serum melatonin levels. And either over 4-hour period or 8-hour period, depending if you have no light restriction. But when you have restricted evening light exposure, you just should be able to make more melatonin, and there they really are not able to increase their melatonin production. They have low serum melatonin the whole night through them. So also in burnout, you might be surprised, but don't be surprised. It might be also oxytocin deficient. Well, oxytocin, you say, well, that makes you more socially interact. But when you don't have enough oxytocin, you have social withdrawal, like here. And that is also found in the burnout syndrome. They isolate themselves from the others. And so here, for example, intranasal oxytocin was given for 2 weeks to patients with post-traumatic stress disorder. And what it did, it decreased the complaints of post-traumatic stress disorder, in particular this avoidance of people. It also had beneficial effects on the heart rate when you were put in several stressful situations. We'll see that more detailed in the session of the model on it. So there's fatigue and social encounters with oxytocin supplementation. You see, this is breastfeeding woman, and they were breastfeeding after 4 or 5 days after delivery of a baby. And salivatory oxytocin was checked after breastfeeding or during breastfeeding and after and before breastfeeding. And what was seen is that breastfeeding significantly increased salivary oxytocin levels in general and the vigor. So the breastfeeding gives a sort of stimulation for oxytocin release, and oxytocin causes the milk to be excreted from the milk glands. But at the same time, it increased the vigor in this woman, and it increased the fatigue and the confusion. And actually, the higher the salivary oxytocin were found in these women during breastfeeding, and actually, the lower the fatigue score was. So it may indicate that oxytocin helps to have less fatigue, at least in breastfeeding women. Now, oxytocin can tackle another problem in burnout syndrome patients. And when you give oxytocin, you can combat almost all types of substance abuse. And this has been shown in animals, but now we also have studies in humans. So it can decrease substance abuse for sugar cravings. How many people don't have that? Alcohol abuse. Tend to drink. If you want to stop drinking alcohol, you probably need to go on oxytocin. And cigarette smoking. Also marijuana, cocaine addiction. So all these major addictions that we have with the food or the drinks or the smoking is combated by taking oxytocin supplements. So oxytocin treatment can decrease the misuse of hallucinating drugs. And here are several studies: cannabis, cocaine, marijuana, ecstasy. So you want to kick off, it's helpful. And I don't really have many patients getting these type of severe drug addictions, but I had several physicians following my recommendations for them. And they said, we really have a very good success with our addicted patients. This helps them. It doesn't solve everything, but it does help great to kick off of these drugs, because they also become more social. They're less anxious socially and things like that. So you don't need to take a drug when you get social anxiety. You just need to take some supplementary dose of oxytocin. So burnout treatment, their basic principles is that you need to give the hormones that cortisol, aldosterone, DHA gives you a very good decrease of the burnout syndrome, but growth hormone takes you out of the exhaustion. So these hormones are important. Now, the little problem is that when you're really cortisol deficient, growth hormone, they increase the cortisol, and we tend to give IGF-1, which increases cortisol, rather than growth hormone. It has similar effects, but you don't have IGF-1 easy in many countries. So growth hormone, give them smaller dose of growth hormone and a slightly higher dose of cortisol to compensate that. Thyroid, estradiol, progesterone may have to be supplied, testosterone may have to be supplied, and oxytocin to get out of. So these hormone treatments is part of a whole program where you improve the food, you take out pollutants, you improve the lifestyle, you also give some nutritional supplements. But it's part of the program, but this is crucial to get fully out of the burnout forever. Okay, now we're going to see Professor Jonas Bergquist. Just see you if you are there. And I have your questionnaire. You're there, perfect. I'm going to take out, stop sharing my screen. I think everybody sees you. Professor, really thank you for being here. And what I found really exciting in your research is that you're searching for diagnostic markers that show what's behind a chronic fatigue, but also I think neurodegenerative diseases. And can you talk about more of those markers? You talked about lactate levels and energy markers. Can you give me some examples of markers and how you detect them in what sort of fluid?
Yes. So again, a pleasure to be with you tonight. So we have focused, or I focused a lot on myalgic encephalomyelitis, also known as chronic fatigue syndrome. But I focused mostly on the neuroinflammatory part of the cause for this disease. So what we are targeting when it comes to biomarkers are energy markers, as you mentioned, lactate. We also look at hypoxia-related markers when we look at ratios between lactate and pyruvate. But also inflammation is one of the major targets. So there we look for interleukins, cytokines, complement factors that are part of the innate immune system.
So in your patients, you have, for example, a low lactate and a low lactate to pyruvate ratio, I believe. And then you have
actually opposite. So myalgic encephalomyelitis patients typically have increased level of lactate, also during very mild conditions, mild exercise or mental activity. So what we see is they produce lactate, but they don't manage to reduce the level of lactate as a normal individual would be after an exercise.
And then for inflammation, you have interleukin 6, I suppose. And also you're using CRP, the CRP protein also as a marker?
Yeah. And what we typically see also, which is of course a problem for the patient with myalgic encephalomyelitis, if you take the normal panels that we get from the clinical chemistry laboratory all over the world, they typically don't show up as very high inflammatory markers. So CRP, for instance, are typically not very high. So that can lead us into a false estimation of that the patient actually don't have inflammation. But when we have a possibility to look more in detail in, for instance, cerebrospinal fluid, and we measure in cerebrospinal fluid then a panel of neuroinflammatory markers, we can see that they actually have an ongoing inflammation, central nervous system related such.
And so you also had talked to me about low energy markers. Which type of energy markers are you checking?
Yeah, so we are trying to follow, it's also a broad panel. So we see energy markers like ATP and NADPH and so on to see if the mitochondrial function is activated and works as it should. And what we typically see is a deficiency in producing energy, basically, in the cells. So
you take that in blood. You have a blood test that you do to get that?
You can do it in blood tests, but you can also do it in cellular material if you isolate blood cells, for instance.
Oh, yeah.
Or in some cases, there's a possibility to do small biopsies from muscle tissue, for instance.
And for example, if patients are interested, can their physicians send samples to your lab?
Yeah, we have samples sent to us from all over the world, actually. We have a collaborative research center with Harvard, Stanford. We have a center in Montreal in Canada, and we now have one in Melbourne in parallel with our Swedish center in Uppsala at Uppsala University.
Is there a website where people can get more information?
Yes, it's you can find us easily at Uppsala University under my name, but also there is an Open Medicine Foundation organization in the United States that have collected these research centers under one umbrella. So that's easy obtainable information about us.
You had also some markers you checked by checking the cerebral spinal fluid. You go in the spine and you check with a liquid a lumbar puncture. What are you checking as neuroinflammation markers in this fluid and the spine?
Yeah, so the ones I mentioned, it's a broad panel. So we actually have a panel of several hundred different markers that we look at when it comes to the cerebrospinal fluid. So it's a combination of complementary factors from the innate immune system. It's cytokines like nerve growth, TNF, IL-6, IL-12, a lot of them that are important for us to see. But then also a cell damage markers that are a panel of apoptotic signaling, cell repair systems that are activated.
So cell damage, you mean, for example, malondialdehyde or like oxidative stress markers, or it's more than that?
We look at both proteins, larger proteins. If we come to the central nervous system, it could be a typical marker could be GFAP. So glial fibrillary acidic protein, which is a marker of cell damage. We have neurofilament light, which is another cell damage marker that we monitor. When it comes to metabolites, typical, one can look at a small molecule like glycerol, but also, as I said, lactate pyruvate, small amino acids, neurotransmitters.
You talked also about neurologic diseases that get antibodies, that are due to antibodies. What sort of antibodies would you check? Can you give one or two examples of antibodies? Is it also in blood or is it in the lumbar puncture?
Yeah, so what we are monitoring is autoantibodies, so antibodies that are directed against our own cells or certain proteins in our body, for instance, receptors. And in our patients with myalgic encephalomyelitis, we see an increase of autoantibodies against muscarinic receptor and the beta-adrenergic receptor. So those receptors that are actually taking care of the signaling from acetylcholine and norepinephrine and epinephrine. So very important receptors.
So these patients are damaging their tissue with these antibodies.
That's one theory. We have to still prove that, I think, because it's not been exactly known yet how these autoantibodies are functioning. But there are some preliminary studies where one have shown that if you reduce the amount of these autoantibodies in circulation in blood, some patients actually respond well on that kind of treatment.
Yeah,
one important thing, though, that we have done.
Please talk.
One important thing that we have found is that when we look at cerebrospinal fluid and the liquid surrounding the brain, we don't see the presence of these autoantibodies. So it means that we probably don't have an intrathecal production of the autoantibodies, no production in the central nervous system. And that's a good signal, because then it means that if we need to reduce these autoantibodies by some measures, it's going to be more easy to address this if it's in the periphery and not in the central nervous
So they're
system.
mostly in the blood that you detect them.
Correct.
So and that makes okay. And then you also talked about something also very exciting, is that you also check the hormone markers or hormone deficiencies they have in myalgic encephalomyelitis, and which is, I think, severe chronic fatigue syndrome. And you were talking about that you were also checking stereoisomers of thyroid hormone. Can you talk more about that?
Yes, this is an ongoing study that we are running right now. And we know that many patients with myalgic encephalomyelitis then report with problems with the thyroid hormone regulation, as you also mentioned in your presentation. So what is fascinating is that in a clinic, in the routine methods, we have T3, T4, and TSH typically measured. And in some cases, those are fine. We can monitor them and see deficiencies or problems with regulation. But when you dive a bit deeper into that thyroid hormone regulatory mechanism, you can actually find a multitude of different markers, both, as you mentioned, also everything from T0 to T4, but you have also the isomeric forms, and you have iodide binding problems in certain of these forms. So it's important to have a multitude of measurements done if you really want to understand this regulation.
So if I understand, if you, for example, the most potent thyroid hormone is T3, you could have several forms in two-dimensional forms structure, and maybe one doesn't really work, and a patient has too much of the one that doesn't work and has not enough of the one that works. So you could have normal levels and still be not responding to a treatment, for example, because you don't have the good stereoisomer. That's interesting.
The problem with doing the measurement is that you have to have quite fancy and expensive instrumentation to do the measurement. So you have to first separate the molecules with very high resolution liquid chromatography or supercritical fluid chromatography. And then you have to measure them with precise high resolution mass spectrometry. So that, of course, combination makes it less available to ordinary labs around the world, unfortunately.
But you have a lab that does that, and you it's probably expensive to do it, but maybe if somebody is interested, it's possible to do it. That's interesting that at least we have the possibility of already measuring that, because that will probably lead to new information. Then you were talking that when you check the thyroid function, you were not just checking the hormones, but you were checking intracellular parameters of thyroid activity. Can you talk more about that? Can you give examples?
Yeah, that's also very much ongoing research right now. We are trying to do measurements of potentially dysfunctional regulation in the tissue over 24 hours measurements, which is then, of course, quite demanding, both for the measurements, but also for the patient. But what one can see is we see this kind of dysfunctional regulation. We call it the vicious cycle in critical ill patients. And we are trying to learn from the critical ill patients in intensive care unit and transfer that knowledge to what actually becomes myalgic encephalomyelitis or post-viral fatigue problems, as we are focusing on. And
normally when I check thyroid parameters of activity, I check, for example, sex hormone binding globulin, LDL cholesterol, alkaline phosphatase, but I think you have 18 or 20 different intracellular markers. So you go a step further, much further.
Mm-hmm. We have actually, for the hormones, steroid hormones, we have in our method now 36 different hormones that we can measure with our technique. So that's, of course, exclusive, but it's a way of understanding more the relationship between the different hormones, also how the enzymes that are regulating the levels actually are functioning and how they are connected to each other.
So it's not only sufficient, it's not sufficient to just take the hormones, you should check the effect of hormones on the cell activity, and that can be checked with other parameters in blood. That's more or less the basis of your... Wow, okay, very interesting. would you have a message for people? Do you have an advice for them if they have chronic fatigue? Could you help them, or would you just give a sort of sound advice, or are you mostly in the diagnosis?
Yeah, so it's hard to give a general advice that would fit everyone because it's a very, very individual disease. We have millions of patients around the world, and each patient is unique in some way. But one recommendation that we typically give is that one try to find out what is the deficiency or the problem that could at least help you treat the symptoms, and also to get good contacts with good specialists to have the most supportive help with your disease. Because what you have to do is you have to keep your energy, and you have to make sure not to crash when you have myalgic encephalomyelitis. And unfortunately, many patients don't respond so well on medical treatments or therapies with drugs typically. So it is complicated in that sense. But what has been shown over the years, and what actually led to recovery, especially in younger patients, is that you maintain your energy level and you're careful not to overactivate yourself. Even if you feel very energetic part-time, you should try to keep your sources and don't over exercise, or don't physically or mentally exercise too much, because then you get what we call post-exertional malaise.
So know your limits and stay just below the upper limit so that you can keep your energy as long as possible. Good advice. What I propose here, I'm going to show some slides. So you take out your video, and then if we can have you for the question and answer session, that would be perfect. So just in 5-7 minutes, be back. Is that possible? Just switch
Perfect.
out, and
yes.
then I can. Okay, perfect. Okay. I'm going to share you my screen. I have some slides more to show. And about information before we go to the question and answer session. And I know there are some questions, as at least 23 questions we have now, is that we're going to have for a firm in Argentina, the VIP firm, pharmacy actually, we're going to have a series of several sessions. They will be translated, but I will talk in English, so everybody can go. There will be about 2 hours that I will personally give with a pause, and that will be in April and in May, usually on the average once a week in the evening. And so we have also this question and answer session for postgraduate students. We have the formation called evidence-based hormone therapy, but there's a lot of nutritional treatments also. And then every month I have a question and answer session for those who have subscribed to the formation. It's very interesting because we also have some case studies now, and there are many, many questions. So it's really worth to be part of the team and do these webinars. There's also a free live webinar like this on thyroid deficient excess and autoimmune disease and hypothyroidism. Very interesting, on April 27. And we'll trying to have a very interesting guest also, as we have now. And so there's a whole evidence-based hormone therapy program where it's beginning to translate to Spanish. So if you're Spanish, it's also worth to be part of the team. It's not only in English. And these are very exceptional courses. And we try to have a top expert also talking in the new models that are on the making now. We're going to have a ghostwriter, we're going to have a professor from Harvard, Abraham Morgenthau, of testosterone. So it's really interesting. And we have within that sort of evidence-based hormone therapy a special part that is only nutritional, that has been separated, that you can also subscribe to this nutritional program. But also, the evidence-based hormone therapy is the one that really gets a lot of success. And then there are books to order. You can order here on the website, hertoghemedicalschool.eu. As if you're a physician or a health professional, you absolutely need this book. This is, if there's only one book, this is the book to have, that talks about the hormone deficiencies and therapies of 18 hormone therapies. And it's really worth, because you really learn how to do it. And then we have my latest book, Testosterone Therapy for Real Gent, where we have everything about prostate cancer and patients taking testosterone, how to reverse prostate hypertrophy, everything you want to know and do about testosterone. Reversing Physical Aging is my textbook on how to reverse the aging of the head, the hair, and the senses, with a lot of interesting information. And then what is also helpful for physicians, Atlas of Endocrinology of Hormone Therapy. I have more than 650 pictures of hormone deficiencies, 20 hormone deficiencies, and 19 hormone excesses. Really, really worth, if you work in the sector, to have this. Is unmissable, I would say. Hormone Handbook and Atlas are unmissable books. For general public, we have the Hormone Solution, the Oxytocin book that is also for physician, where you have everything on oxytocin, and the Patient Hormone Handbook, which is a reduced form of my best-selling Hormone Handbook for physicians. Really helpful because many patients want to be their own health manager. That's the book to have. And then we have partners under which we have also Nicolas Lecordier. I think he's going to talk. That's one of our, and I'm trying to put here. Yeah, that's it. Letting him talk.
Hello, I am Nicolas Lecordier, Sales Director of Laboratoire COPMED Benelux. Born from a family ambition, it's been 25 years now that Laboratoire COPMED perceives health from different perspectives. Prevent beyond healing, thanks to natural health products. All our team is every day doing its best to honor this founding principle by developing natural and high-quality products that are elaborated, thanks to a recognized technical and scientific expertise. Our engagement is global, from content to packaging. Our pill containers are indeed 100% vegetable and elaborated from sugarcane. Our capsules are also vegetable, as they are made from tapioca. Thank you for your attention.
Thank you, Nicolas. It's a really firm that is sustainable. I mean, looking in the future and getting organic and very sustainable things so you don't get any pollutants in it. So really good. We have a lot of other firms like Nuturgia, Nutri-Essentiel, Biosil, Forsthaus Apotheke, Urfa Thyroid that Canada helps us, Longitave Solidavel, Your Health, Anti-Aging Systems, very, very good firm where you get what you cannot have elsewhere. Tailor-made compounding, also interesting. LIMS Labo, BioNeuriso, also it helps us with this Spanish translation. Really thank for them. They're really good partners. And then Pay Compounding Pharmacy, Laboratoire Réunis, Access Labs, Qualifita, etc. So I'm surely forgetting some, but really we're thankful, grateful to you. And then you can follow me on the social networks, but it's a whole movement. We're trying to get information out there. You have Facebook, you have the Twitter, you have LinkedIn and YouTube videos, interesting. And if you need additional information, you can go on the website, Hertoghe Medical School, or email to the office.hertoghe.eu, the office at hertoghe.eu. You can get the information that you need. So I really thank for your attention, but we're going into the questions now, so don't leave. And we'll look at the questions and I'll stop sharing the screen. Professor Bergquist, you can come back and I will start with the questions here. Okay. Here's a question. Suggestions slow the spread of vitiligo. Well, vitiligo is usually with autoimmune antibodies, and usually these patients have adrenal deficiency and may also have yeast infection. So what I do is I treat the adrenal deficiency and I give eventually put locally anti-yeast products and stop the yeast product. Can Hashimoto's disease be reversed? Yes, and I will talk more about that the next time. And it's but you have to do a multiple treatment. In what lectins, oxalates, salicylates, histamine, phenols, sulfites, intoxication when we normally need vegetables? Here's a patient asking that with vegetables, you can get some problems with histamine and other. I don't know if you can talk more about that, Professor Bergquist, but I personally, we make patients avoid foods that give more histamine, but all the other things I'm not so knowledgeable about. I don't know if you know more. No?
No.
There are many questions, so there will certainly be other questions. Some people say that one should eat carbohydrates and proteins separately. They say we should eat proteins with vegetables or carbohydrates with vegetables. I think it's true that there's a basis that you should not mix too many different foods, and you shouldn't eat fruits, for example, during a meal or after a meal, but before a meal, half an hour or 3 hours after. When should you take each supplement? If good for energy all day, should you take them early in the day? Yes, if it's a supplement gives you energy, generally it's the first thing you do in the morning when you wake upon awakening. Some supplements are fatty solutions and they may be better absorbed during the breakfast or the meal. So you eat them during the meal, but I usually always propose first thing in the morning when it's something that gives an energy the whole day. When should you take iron? That's after the evening meal. It's better absorbed on empty stomach, but the problem, you get much more problems of digestion. So the iron is best to take then in order to avoid digestion problems after the evening meal. Then you don't eat anymore, and it's better to tolerate this way in most people. How do you change the older of 80 years to desiccated thyroid from synthroid that we have been on it for many years? So patients who had taken thyroxine, T4, only during many years has to switch to desiccated thyroid. Well, you do it very slowly, and this will also be discussed in the next free webinar. The switch over, you have to go very slowly, you decrease one, and you increase the other very slowly over 2 or 3 months. Prevent hair loss. Well, we saw that already earlier. There are many nutrients that help prevent hair loss, but it's such a long number. There's silicium, for example. There's iron. And there are many hormones that prevent hair loss, but you can read my textbook of hormone therapy. Can you please expand on when 2.5 milligrams of cortisol creates headaches? If people get headaches with cortisol, even the slightest dose, it can depend. There are many different possibilities. It's usually that they have other hormone deficiencies that are not corrected, like aldosterone deficiency. And it could be that the 2.5 milligrams of cortisol, which is not much if it's a bioidentical one, it can increase the blood pressure too much, and they get headaches by increase of blood pressure. So we have to avoid salt in these patients. And to probably give a little aldosterone, which actually itself increases blood pressure. So it has to be seen individually. It's too difficult to give a straight on answer. Vasopressin or aldosterone, could these help a patient with chronic kidney disease, or what would you look for? In patients with chronic kidney disease, they could have aldosterone and vasopressin, but they often have high blood pressure. You need to be careful. You don't give aldosterone or fludrocortisone to a patient who has high blood pressure. I'm going to see if I can find a question for you, Professor Bergquist. How would you recommend chronic early awakenings, 3-6 a.m.? Chronic early awakenings often in people who take too much melatonin. They have to lower the melatonin often. And then it's a sort of a benign tumor in the brain. Can it be source of fatigue? Yes, of course. But what to do with, I don't know. That you probably have to take the tumor out. Is it the growth hormone injection that helps IGF-1, or is there an IGF-1 injection? There is also an IGF-1 injection. I don't know if you know Professor Bergquist, but we work with growth hormone and also insulin-like growth factor 1, which is normally given to children with short stature, and both help to take exhaustion away. And after age 50, everybody gets deficient in both, and actually it helps both people. But that's in the most severe chronic fatigue syndrome. You had actually, you examined mostly the most sick patients among the chronic fatigue. So is there a special definition to be labeled myalgic encephalomyelitis?
Yeah, we use the Canadian criteria, and also the Institute of Medicine have made a criteria, that consensus criteria that we are using for for the stages.
And it's criteria of myalgic enteromyelitis or criteria of chronic fatigue syndrome?
Well, it's a bit of, I think it's a mix of let's say both, yeah, because also there is another term called SAID, which is then exertion. So it takes PEMS into the picture also. So it's a combination of different consensus criteria that we're using, but it depends on also if you're setting diagnosis or if you're selecting patients for research, for instance. You have to be different in how strict you are on the definitions here.
Because myalgic enteromyelitis means that you have pain in the muscles and that you have an inflammation of the brain and the spine.
Yeah,
basically. But not all chronic fatigue syndrome patients have that, or do they have that?
No, not everyone have that, or at least not measurable terms. So I think there are definitely subgroups of patients in this cohort. So that's why we need these measurements, the better diagnostic tools by molecular features.
Because in my latest workshop some days ago for Mexico, there was a question. I said, they didn't say it, I'm desperate. They said, I have myalgic enteromyelitis. What can you do about it? Mm. And so I suppose it's a patient who has the diagnosis officially and has more information than other chronic fatigue syndrome patients, I suppose.
Mm. Yeah, so there are different trials being tested around the world now for reducing inflammation. So far, none has been extremely successful, I have to say. Unfortunately, we had initially a positive effect of rituximab, which is then suppressing immune system and suppressing antibody production, but it turned out not to be a sufficient treatment. So now it's not recommended.
Okay.
Yeah, it's not recommended.
Well, need more research then. Okay. And then can we use hormones to treat depression? Yes, and I'll probably have a whole module on depression, anxiety. Actually, one of my next books, I hope, if I have time, because I don't have so much time now, will be on how hormone therapies can help psychiatric diseases, including depression. So let's say if you have a whole day depression, it's usually sex hormone deficiency. If you have a morning depression, mainly, it's usually thyroid deficiency that can be a cause of that. And in my experience, you have to know that I started training as an assistant in psychiatry, and I saw so many hormone deficiencies in those psychiatric institutes that I said, well, I'll be more efficient when I give hormone therapy. And I was indeed more efficient when I started to work in hormone therapies. Primary biliary cirrhosis, will this make fatigue chronic? Yes, it can, but every fatigue can be decreased to my experience. Keep the hope on. Can I see the previous web seminars? All the free webinars are actually remain free, have been recorded, so you can see all the other free webinars. But if you want really to get in-depth information, it's better to go in the whole training program that is really worth it. Because I usually do good conferences, but this is just a better level. Sorry, just joined. Will the recording be available? Yes, the recording will be available after. We have actually 2/3 of people after the last free webinar of the beginning March. We had 8,000 people, and we had actually during the recording about 1,000, and then it was 7,000 more. I have seen it after. In chronic fatigue, if the hormone treatment is stopped, does the fatigue come back? Yes, it does, because fatigue due to hormone deficiencies come again if you again have the hormone deficiency. So it's a treatment that hormone treatments work as long as you continue taking them, because in general, people with hormone deficiency have persistent fatigue. What about fatigue and sleepy once sit down? When you sit down and you get sleepiness, that fatigue is typically due to low thyroid. But if it's low blood pressure, you get lightheadedness, that's due to low aldosterone. So it goes away if you are corrected for the hormone deficiencies that has been behind it, if you have checked, of course, the hormone deficiencies and made the good diagnosis. Why doesn't hydrocortisone work even if fraction 3 times a day? Many people take a too low dose of hydrocortisone, so it cannot work. hydrocortisone is bioidentical. Cortisol has to be taken several times a day. I take it normally, it's twice a day sufficient, 3 times cannot, but you need to take enough. And I have seen physicians only giving 5 milligrams at a time, and that for most patients is insufficient. Can you measure thyroid deficiency from heart rate? We'll probably have to stop a bit some of the questions because there is, I've assigned that I may not continue too long. Can you measure thyroid deficiency from heart rate? Of course, the heart rate is quicker when you have more thyroid ones and slower when it's slow, but it's not a diagnostic test. It's just one parameter. I said here, say hello to beautiful Stockholm. So you have a fan there.
Thank you. I will.
So, do you know more about polymorphism of the deiodinase type 2 gene? You know, it's well, maybe I can.
Not so much. Yeah.
Well, the T4 gets activated into T3 by what is called an enzyme deiodinase, and the type 2 deiodinase makes most of the T3 for the body. And people that can have a genetic deficiency in this enzyme and not make enough T3. And those patients have been shown in studies, they do much better if they get a T3 and T4 combination than a T4. And there's a genetic test you can do by saliva. I lost audio when Dr. Bergquist began speaking. Okay. Has this been recording? Regarding burnout, what are the criteria? Okay, I'm trying to find a question for you. For scheduling appointment, you have the clinic. You can always shell. Where do you see the overlap? The questions that I have just started with the treatment, how to combine. I'm not having any more questions. How do we diagnose fatigue if it differs from day to day? Some days more in the morning, some days, sometimes all day. Do you have an answer for that?
No, I mean, the patients we see have a constant fatigue, most likely. They can recover a bit during late days, but it's 25% of the patients have a possibility to be fairly active. They can maybe maintain schoolwork or go to work. 25% will stay in dark rooms without any physical activity, any stimuli. And then there's everything in between there. So it's a big and very broad spectra of severity, I would say.
Yeah, so you have mostly exhausted patients, I suppose. That's really that don't recover actually. I would say for people who have less than exhaustion, if they vary their energy a day, it's often due to a wrong food intake because some food, and so if they eat sugar, then they will be more tired the whole day after. If they eat too much or too little, that may also make a difference. Fasting gives more fatigue, but if you eat too much, that can give also post-meal fatigue. So I think it's mostly due to the food that they may have these differences. It also could be to some people have pollutants.
Our ME patients are typically, I mean, I'm being a generalist now, but typically they are very careful with their food intake, and they are very they know about food intake a lot, so they're very careful with what they eat and how much and so on.
But that explains maybe why they don't have ups and downs in them. So that's at least a good thing. I probably had COVID-19 in February 22, tested negative on PCR, etc. Since then my lungs are crunching. Special morning, I take alpha timers and alpha-1. I've tried antihistamine, nothing seemed to work. The lungs remains crunchy and I'm very exhausted. When the lungs have been attacked, you need to repair them by anabolic hormones. And it's actually a little growth hormone, but mostly IGF-1 that gives the best efficacy. So you need to go to IGF-1, and then I think we're almost. Maybe a question for you, Professor. What is your experience with Nexavir, former Cutapracin, in the treatment of chronic fatigue syndrome, and perhaps would this work with burnout? Do you have
we haven't done any, as far as I know, there are no clinical validated tests on this or trials with placebo-controlled studies. So it's very difficult to say, I would say in this case. I just wanted to comment on the COVID-19, since that's sort of on everybody's mind right now. So what we are doing currently is we are monitoring the most severe COVID patients, those that end up at the intensive care unit. and in ventilation and long-term hospital treatment. And we see once they are released from the hospital, they also have post-viral fatigue and neurocognitive issues. So we try to learn from the most severe ill with the well-known now virus infection and see if we find any similarities. Also learning potential treatments, strategies, and mechanisms behind the fatigue that the viral patients have. So I think that is an option for us now in this catastrophic situation that we're all living under. We can still learn something and actually create some new science here.
Yes, and it's also a question, I think maybe from Sweden. What suggestion do you have for POTS? But I don't know what POTS is.
Yeah, so POTS is dysfunctional regulation of blood pressure, you could say simply. POTS patients actually have the similar type of autoantibodies as we see in our ME patients. So they have this autonomic dysfunctional regulation of blood pressure, for instance. Treatment-wise, blood volume increase has been shown to have some good effects, but it's still, there's no evidence for the treatment, I would say.
So it's patients that have, by time to time, a sort of drop in blood pressure, if I understand, but it's irregular.
Because and they have also a combination of drop in blood pressure and tachycardia. So
yeah. That's often with low blood pressure. We had a patient from, I think, Sweden, exactly like this, who had to be brought in a bed here with a perfusion, constant perfusion. And actually it was solved just by giving fludrocortisone. They had forgotten to treat the adrenal deficiency. We then give cortisol by identical, which increased the blood pressure, and fludrocortisone, and that helped. So that helps. Here's a question about how many consultations, blood tests a year does it take to undergo treatment? On generally, the first year, there's 4 consultations if it's at my place, and then every 9 months we receive the patients, and they seem to do well. Sometimes when they go from very far, after the first year, it's every year. So that gives some information. Okay, I think we're at the end. There are many more questions. I'm sorry I can not answer everything, but I'm really happy and I'm really honored to have had you, Professor Bergquist. I did find that you really give to me also new insight, new information, and I think it's the case for all people who have learned. So really thank you and for your participation.
All the best and take care. Thank you so much.
Bye-bye.
Bye. Thank you.